we're going to start in a few minutes. If you have not signed in, please sign in up here. They're using modern technology called the internet, and it just died for a few minutes. So they're gonna resurrect it, then we're going to get started, okay? Thank y'all so much for being here. And while we're doing that, we just want to open. We are a Christian church, and we're going to open with a word of prayer and just thank God for being here. Y'all look so good today. Thank y'all for coming out as we try to get our health ministry with information back on the road. And we're doing that, and you're helping us. Thank you so much. I look like it's up, so we're ready to go. Let us pray. Father, we just thank you again for this day. We confess that you've been good to us all morning. You woke us up, and we thank you for that. Now, Father, as we come out to the church, the house of worship, to learn other things, we thank you for your wisdom into us. Bless this setting, and we will give you the praise, honor, and glory. In Christ's name we pray. Amen. Amen. Now, our presenters, Mr. Hodo will present our presenters today.
Hello everyone, good morning. How are we doing? It's really nice seeing you all on this lovely Saturday morning. My name's Dr. Grover, and that's Dr. Sangwan. We're both residents at Wellstar Spalding. Today we're going to be talking about something very important, something we encounter very often in the hospital, in the clinic, something that sneaks up on us very insidiously and then takes over completely. How many people here have taken care of someone with dementia? Can we give them a huge round of applause? We're gonna go over the science of it just a little bit. Dr. Sangwan's gonna talk about what causes it, what to expect, and then I will go over how to take care of someone with dementia, what treatment there is in today's medical world. Feel free to stop us, to ask questions, and we will do our best to answer them, okay? I'm gonna hand over to Dr. Sangwan.
Hi, good morning. How you all doing? It's great to see your faces here, and we are ready to talk about it. As Dr. Grover just said, feel free to stop us, ask a question, or if you have any doubts, we're here to clarify them. I'm going to be talking about the science part of it, a little bit the medical side of it, and then Dr. Grover is going to be talking about caregiving for people with dementia and so on and so forth. Little tips and tricks that you guys can inculcate in your daily life, and that's really helpful. So our presentation is called Understanding Dementia. The objective over here is to just understand dementia, recognize the signs and symptoms, because very often the first people who start recognizing signs of dementia are the family members. Doctors are not at home with patients, so family members are the first people who start seeing signs. What dementia is just an umbrella term. Dementia is a big term that includes many different types of conditions under it. And that's what we call an umbrella term. It's just when a patient's memory, personality, behavior, social abilities gets affected. And it gets affected to the point where their daily life starts getting affected. They start hanging out with friends, and the friends start noticing things are different. They are not able to take care of themselves as they used to earlier. These slow, small changes every single day is called dementia, and there are many conditions that can lead to that. That's what we're going to be talking about here. It is an extremely common condition. It affects almost 47 to 50 million people worldwide in all countries. People of all races, ages, after a certain age, genders, everybody gets affected, and it's extremely common. And it has a huge economic burden as well, because just of the amount of population that gets affected by it. What I'm trying to say by this is, even if you haven't known people with dementia personally, it is an extremely common condition out there, and many people are affected by it. So I'm just waiting for her to change the slide, so we move on. The thing is, I know over here, so many people raise their hands with regards to that they have cared for people with dementia, and that is great. We have people who have had first-hand experience with it, which is really important with understanding it. But our goal over here is to just give you an idea for what dementia is and how to care for people with dementia, even if you have not had first-hand experiences. The key point over here is that dementia is not normal aging. As we grow old, things start to change in our body, right? That's normal. We've been growing old ever since we were kids. The thing is that aging is mostly normal. After a certain age, though, sometimes some people start getting affected in ways that is not normal. That's what dementia is. That's what I meant earlier when I said that your daily life starts getting affected by it. You were doing things earlier that you were not able to do anymore. Maybe you were aware of it, maybe you're not, but your family members start noticing things that you're changing in a certain way. The important thing is to realize that's not normal and when to seek out help, and that's why we're here. That's what we're here to talk about. There are certain risk factors for dementia. The number one is age, because it starts affecting people after a certain age. There is no set age limit as such. There is no age number which you can just look at and be like, okay, after this, I'm gonna get dementia. That doesn't exist, but the risk of getting dementia increases significantly after a certain age. Can you go back? Thank you. There is a genetic component to it as well. I think this is one of the most frequently asked questions that we get as providers and as physicians as well, that if there has been a person who had dementia in my family, what are my chances of getting dementia? Am I going to get it as well? Am I going to be affected by it? So the biggest takeaway over here is that it is not 100% genetic. There is no such research, or there is nothing out there that says, yes, if your mom had dementia, you being her child is going to get dementia as well. But that being said, the risk does increase significantly. And that's why I think you should know for yourself as well as for your family members what the signs and symptoms are. Because your risk does increase significantly, but there is no direct correlation. No one can just look at your family history and say, okay, your grandmother had dementia, you're gonna have dementia as well. That doesn't exist out here. Strokes can increase the risk of dementia as well. A stroke is where basically a phenomenon where a part of your brain stops getting blood for some time, and then you have a stroke. People can get weakness with it. People can get, numbness, tingling. They can feel different in their body because that is a phenomenon that's happening in your brain. It tends to increase the risk of dementia later on as well. And then other comorbidities, which is just other medical conditions like diabetes, hypertension, high cholesterol, obesity. These are all conditions that, if present altogether or maybe just one, it does increase the risk of dementia later on. And then lifestyle risk factors are really important as well. As we all know, things like alcohol, things like, other drugs out there, all these things, it's just a multifactorial thing. There are many things which increase the risk. These are just few of them. So how does dementia present? As I said, family members are usually one of the first few people who notice things. And the word abnormal is important over here, but not in the way what it means. It's just when you're living with a person, you know what they do day to day. You know how their daily life is. You start noticing these little things now and then, which you feel like is not their normal. And normal is different for everybody. Everyone has different normal things that they do in their daily life. And the family members usually know at their homes that this is maybe not their normal. You see a little thing one day, and then 2 days go by, and then on the third day you see something else. And then it just keeps increasing this pattern of you noticing things. That's where usually people start noticing signs and symptoms of dementia firstly, inside their own homes. And these are just some of those things that you might notice. Now, the severity of these things can be different because it As I said, dementia is just an umbrella term, and then you have many conditions under it which can cause it. Similarly, dementia, the word, it doesn't really have a single thing associated with it. Oh, I am having memory changes. Do I have dementia? It's just not one thing. You can get affected by a multitude of things, and these are just a few of those things. You can see your family member having a certain change in their personality. They were really easygoing earlier. Now they are kind of abrasive. They have suddenly become distant to you. And that has been a recurring pattern. You start noticing it. That is one of the things that you might notice. They get a little more sad than their usual amount. They feel depressed. They feel down. They feel anxious. They are agitated. Again, these are all things that are different from what their normal is. And then it's important for you to just recognize the difference in that, the contrast between their normal and the changes that you're seeing in them right now. Some other things can also include them being suspicious, them not trusting you enough, you saying, food is ready, it's time to go eat lunch. They don't want to eat lunch. They don't trust you that it's lunchtime. They think it's dinner time. They don't want to eat food. They don't like this food. They've been liking that food their entire life. They've been loving that one meal that you prepare. They don't like it anymore. Things like that are abrupt changes, but also you see over a period of time. Things like that are usually some of the first few things that you notice inside your own home. So, as I said, the causes of dementia, because it's just it's an overlying term. There can be many causes for dementia. This is an easy way to kind of go over some of the causes. Now, dementia can have causes that can be reversed, and dementia has causes that cannot be reversed. Some of the reversible causes include delirium. Now, delirium is just something where people feel a little confused. It can happen inside a hospital, it can happen outside a hospital. It's just a confusion level beyond there, which is something that is their normal. The most common example of delirium would be a patient gets really sick, right? A person is sick, a family member is sick. My brother gets fever, for example, and he has really high fever. At home, his fever might lead him to be a little confused. He doesn't really know where he is right now. He doesn't know what time it is right now. Delirium is when you are sick and you feel confused. That can actually be a cause of dementia, but that is something that can be reversed. My brother, if he has fever, I can give him Tylenol. The fever goes down, his delirium goes away. That is just an example of delirium. Emotions can lead to dementia as well, and again, that is a reversible cause if a patient has depression, for example. We have, therapies out there. We have medications that we can help to control that part, and then that can be reversed as well. Metabolic disorders, that just is things like diabetes, your thyroid issues, just things in our bodies that we can try take care of, and then we can try reverse it to the best extent that we can. Eyes and ears impairment, this is extremely important as well. Beyond a certain age, our vision and our hearing starts to get affected. That can be part of a normal aging process. When it starts getting affected to a certain point where the person doesn't feel comfortable because they can't hear what you're saying to them. If you're sitting right here in the front row and you just can't hear what I'm saying, you're gonna be confused. You're gonna not feel good. You want to know what the other person is saying to you. Same goes for your eyes. If you know your vision is kind of deteriorating or changing and you need glasses, you haven't changed your glasses for many years, that's gonna lead to some confusion. That's not gonna make you feel really good. You're gonna get irritated a little bit. You're gonna be like, why can't I see? Things like that are all reversible, and we can try taking care of it. Some other things are vitamin deficiencies, vitamin B12, vitamin B complex. We have those supplements available over the counter. They can really help in managing this, and then again, it's something that we can reverse. Some other things are trauma. If a person gets into an accident, for example, if they get some trauma to their head, again, the brain is right there. If you get trauma to the head, high chances of you being confused a little bit. Some infections can lead to it as well. And then, as I said, alcohol. All these recreational things, as we call them, drugs, alcohol, continuous smoking, and there are so many things out there. All of these can also lead to it. It can be a factor in one of those many factors that can lead to it. There are some irreversible types of dementia as well. These are the things which cannot be reversed. We cannot treat them, but we can manage them. We cannot cure them, but we can take care of them. We can make sure that the patient is living a comfortable life and we are doing best we can. These are things including Alzheimer's disease, which I'm sure everyone has heard a lot about. It's one of the most common irreversible causes of dementia. Again, Alzheimer's disease is something that affects people above the age of 65 usually. That does not mean that it can't happen under 65 as well. It's just more common above 65. The other thing is vascular dementia. Vascular dementia just means you have had vascular, the word means vessels, which refers to blood. And that is referring to the thing I talked about earlier, which is strokes. Strokes can increase the chances of dementia. If you have changes in your brain, including blood not reaching certain parts of your brain, that's called a stroke. And that can lead to vascular dementia over time. Some patients get little strokes over time, and then that can just affect different parts of their brain, and in the end, they're just confused. They don't know where they are. They don't know this is their house. They don't feel comfortable here. They can have vascular dementia. Frontotemporal dementia is another type of dementia. This is when you have changes to the frontal part of your brain, and this is usually associated with severe personality changes. Patients, again, as I said earlier, they were pleasant, they were affable, they love talking to their friends. Now suddenly they're abrasive, they're aggressive, they don't like you anymore. Sudden changes, frontotemporal dementia. Lewy body dementia is one more. These are all medical conditions, but Lewy body dementia is when a patient has something like Parkinson's disease along with dementia. They also can have aggressive changes. They can have personality changes. Personality changes usually affect dementia, all types of dementia, but these are certain medical conditions which can just lead to dementia as well. The patient has a condition going on, and also they have these changes in their cognition. They don't understand that it's time for tea. They don't want to drink coffee anymore. They are throwing the coffee away at you. Or maybe it's just them being quiet and sitting in a corner. They don't just want to talk to you anymore. There are changes that can be different for everyone, but these are just some conditions that are irreversible, so to say. So one of the most important questions is when you should go see your doctor. If you know someone in your family or anywhere near you with these changes and you have some questions about it, you have started to pick up on these signs and symptoms and you feel like they're just not their usual self, they're not their best self, usually this shows up in memory problems. They don't remember they just had breakfast. You guys just had breakfast outside. The weather is nice. They don't remember any of that. And that is a pattern that you see is recurring. That can be one of the reasons why you might want to go to the doctors with them, have some questions for the doctors. The other thing is thinking. They don't understand that it's time to take their medications. They have diabetes medications they've been taking for their entire life. They don't want to take it now. They don't know that they have diabetes. They're suddenly confused why you're telling them about this condition called diabetes. They are refusing it. They liked playing with their grandchildren, their grandkids. They don't like doing that anymore. The grandkids are right there. They are just not interested in playing with them. These are just some examples. These are not necessarily going to be seen everywhere, just some examples for you to just notice when it might be a good time to go to the doctors. So when you go see your doctor, there are certain things that you can ask for the family member that you're going to them for. The first question can be, are these memory problems normal for my age? This refers to what I just talked about a while ago, which is everybody ages, everybody is growing old, that's normal. It's our duty, it's basically on us to recognize when that aging has become not normal. That is memory problems. We all forget things. I still to this day walk into a room and I don't know why I walked into this room. I'm confused, I don't remember. The thing is, when that starts affecting your daily life or the daily life of your family member, that's a good time, or that's a good question that you can ask them. Is this normal? They don't remember eating the last meal with me. We had a good conversation, they don't remember that. Is that normal? The other thing is you can ask them things like, could this be something more serious like dementia, which is what we're talking about over here? If dementia, what type is it? It's really important to recognize that dementia, again, is just a broad, wide term. There can be many different types of dementia. And the reason why it's important to know that is we manage every type of dementia differently. Some things, as I said, can be reversed. If it is being caused by a vitamin deficiency, for example, we test the patient's blood, the vitamin is low, we can try supplementing that, and that helps for some patients. If that dementia was associated to that, we can try fixing that. For some other patients, it could be because of strokes. They've had 4 or 5 strokes in the past. We are going to try to manage that the best way possible. But it's important for family members to know what type it is exactly, so we can try managing that, and then they are also in the loop. They know what is happening, they know what is being caused right now. What stage is it in, and how fast will it get worse? That refers to the phenomenon that when a patient gets dementia, it's not an end-all be-all. It is not, if you have dementia, you just have dementia. More often than not, patients do deteriorate over time. They can just be stable, or they can have times when they're okay, times when they're not, times when they're okay again. But it is important to recognize those dips and coming back for family members, because they are living with the patient, with the person. But it's also important to know how, in what stage it is in right now, and at what rate will it change. Because sometimes you don't anticipate that it's going to become different. And then sometimes it becomes different really fast, and that can be scary for family members living with them. But it's important to just be looped in with that. And then that's just a question that you can bring up to physicians. Yes. Yes. So that's a great question. That takes me back to where I said, so dementia can be, because it depends on what's causing it. It can be a reversible cause, or it can be an irreversible cause. If it's a reversible cause, and that's what we work up patients for, when a person comes to us, we're going to be working that up. If it's a reversible cause, we're going to test their blood, for example. Let's say they have a vitamin deficiency. They have 2 or 3 vitamin deficiencies. That can lead to symptoms that look like dementia, like vitamin B12 is really important. We can try supplementing that, and then if the dementia was being caused by that, we will usually see an improvement. But if it is because of something like Alzheimer's disease, which is something that we can't reverse, if a patient has Alzheimer's disease, that's when we're just going to try to manage it the best we can. And also, if it's going to get worse later on, it varies from person to person. There is no one such rule for patients with dementia that it is going to get worse. But that's why it's important to just know at what stage they are right now and how different they are from their baseline, if that makes sense. You had a question too, sir? Can we put the next slide, please? Thank you. Uh-huh. Can we go back? Mm-hmm. Okay, that's another great question. So when a person comes to us for the first time, we're seeing them for the first time, let's say that's a new patient, the family members are telling me, it's been 6 months, she doesn't seem the way she was normally. She's a joyful person, she's not anymore, things are changing, they've noticed a pattern. Family members are the ones living with the patient, so I go ahead with what they're telling me, and then some of the ways we can test that is we have the blood that we can test for certain things. Like the vitamin deficiency I just mentioned, we'll test the blood for that. We'll also test the blood for things like, do they have an infection going on? Sometimes you don't look like you're sick, but there's something going on inside. We're going to test the blood for that. The other thing we can do is imaging. We can do imaging of the brain. We can see if there are some changes going on. For example, with some of the non-reversible things like Alzheimer's, and the vascular dementia, which is caused by strokes, we can see changes on imaging. So we can maybe do an MRI for the patient, and we can see what exactly is going on in their brain. So it's a very comprehensive workup that we do. to make sure that we're keep taking everything into consideration, and then we just find out what it is, and then we rule that out. We try to fix that, we rule that out. That's how we figure out what type it is. Okay, so for care and support, there are certain questions that you can ask physicians or your primary care physician if you're taking care of a patient who has dementia. And these are really important questions for family members because, as I said, you are the people who are taking care of your loved ones with dementia. You want the best care for them as possible. An important question is, can you make sure that they live at home with you? Or do they need to be at an assisted living facility or a nursing facility or something that gives you external help? That is, I think, one of the most frequently asked questions, and it's a really important question as well, because if you're caring for a person with dementia, your life is also getting affected. It is affecting your daily life. Your schedule has to be changed. You need to change things about the way you're living life as well. An important thing to note over here is, again, it's different for every patient, it's different for everybody. The time to ask this question maybe is if you have started noticing that your loved one who has dementia needs 24/7 care, if they always have to be supervised, if you get up to just go get a pen, you're doing your Sunday crossword, you want to go get a pen from the other room, you come back and your loved one is opening the window or they're in the bathroom. You left them alone for 5 minutes, and this keeps happening. They are not really good at being on their own. You can't leave them for 5-10 minutes without worrying about them. That is a good point where you can start this conversation with your primary care physician as to, is it okay if they live here with me, or do they need round-the-clock care? That is an important junction where you should be asking all these questions. Another important point is, if you need extra help, sometimes it's really difficult. People have jobs, people have their lives, their loved one is at home, and they're changing a little bit. You notice these changes with them. You need help, and that's okay. That's not a bad thing, that's not a wrong thing, you need help. That is an important point where you can bring up to your primary care physician when you're talking about your loved one, saying that I need extra help from the outside, I have these engagements that I need to be at. That is when assisted living facilities and nursing facilities can prove to be really helpful for you, because it's not easy taking care of a loved one who is going through these changes. Who will help and when, and then also a social worker. So social workers are there to help us, to help patients, families, and loved ones. There are some great resources out there, but again, these resources can be given to you at your primary care physicians or at the doctors. And that, again, this is the point where you should be asking these questions. I need more help from the outside. Who exactly can help me, and when can they help me? Do I need help for 5 hours in the morning because I'm not at home, or do I need help for most of the day because I am struggling a little bit? And that's okay. That's okay. It's not easy to take care of a loved one who's going through dementia. So there are some living arrangements and emergency planning that we suggest for people who are living with loved ones who have dementia. So falls are the most important thing. Now, a fall or falling down is not good for anybody of any age. It's not fun to fall. You get hurt. Kids fall all the time, and same for people above a certain age. For example, let's say above 60, above 65. Falls are not good. Falls are worse when people have dementia. You are already confused. You don't feel good in your own home. You don't recognize what time it is. There are these changes going on. And if your house has, let's say, toys lying around, or it has these steps outside your house and you're walking outside, falling like in that way with dementia is not good. And it's always best to minimize the risk of that happening. So for people who are living with loved ones with dementia, we always suggest to keep the walkways clear. Make sure you have good lighting in the hallways of your house. If you're in the living room, make sure there are no too many chairs lying around, because if your loved one's going to get up and walk to the bedroom, you don't want them to hit a chair and then fall. That's not going to be good for anyone. You can also have safety tools like grab bars. Getting handles installed in the bathrooms is always a good idea after a certain age. They have the handles and grab bars of different sizes. They can be placed in different positions. It can be anywhere in your bathroom, but that is always a good idea. And then using non-slip support is also a good idea because, again, as I said, we always want to try to minimize the risk. We can't 100% prevent anything from happening, but we can do our best. So using non-slip mats, for example, is going to help them walk easier, reduce the chances of slipping when they are in their own home. And then emergency contacts are also important. When you have a loved one who's has dementia, it's also important to not forget the rest of the conditions they have. They could be dealing with diabetes for their whole life. They could have high blood pressure. They need their medications for that still. There can be a time where you need to take them to the ER, for example, or even to your PCP, your primary care physician, and you should have, it's always best to have just a list of things that they are taking their medications for. It could just be 2 medications, it could be a long list, but that really helps for us to know and also for the family members to know what they are being treated for. It's always also important to have a list of their allergies. You can have allergies to food, you can have allergies to medications, you can have allergies to pollen, to dust, dander. It's always the best idea to have it for them, just in cases where you need medical attention suddenly. It's always to just have it written down somewhere. And then planning ahead. This is also an important discussion that we usually have inside our office when we see patients and their family members. It's important to have legal and financial documents in place. No one knows what's going to happen tomorrow. That's just how life is. What you can do is always just prepare and do your best. I think it's always important for people after a certain age to just think about what documents, legal, financial, property documents related to your work or your family members, what can be just kept safely. It's always good and a good idea to arrange these things into a file, to have them handy, to discuss future preferences. The patient's say is always the most important. You get to decide what you want for your own body. This is your body. You have 100% autonomy. That you can make the decisions for future. You don't have to make the decision right now. And having these conversations doesn't mean that something's about to happen right now. It doesn't mean that something's about to happen within a month, but it's always best to just have this advanced directives, documentation on hand for you to just have this conversation with yourself, with your family members if need be, as to what you would want done with yourself. And if you have other family members in your home, you can also bring this up with them to see what their preferences would be. Because when people get really sick, sometimes they're not able to tell us, they're not able to verbalize what they would like. So it's always better to have these documentations on hand beforehand. It's always a good idea to have a living will made when early on. Again, no one knows how situation is going to change. And that being said, I'm not saying that situations are going to change anytime soon, but it's always good to have a will that helps a lot. Inside a hospital, outside a hospital. It's also important to have the conversation about getting a power of attorney for healthcare and finances. Sometimes patients are in a situation where they're not able to speak up for themselves. They are extremely ill and we're trying to take care of them. But it's always handy if we get those documents from the side. Family members bringing these documents over, it helps us to guide their medication and their treatment, their therapy as well, also inside the hospital. And then planning for future costs of care is really important as well. Financial planning, making sure you have savings, the insurance side of things. All of that is also important for yourself as well as for your loved ones. Screening for dementia. So this is a frequently asked question as well. Do we screen people for dementia? We can have a 55-year-old, a 60-year-old patient coming into us, again, bringing up that my great-grandmother had dementia and my mom took care of her. I want to be screened for dementia. What are my chances of getting dementia? We usually do not screen people for dementia, just because research has not shown it to be beneficial. If you are completely asymptomatic, if you don't have any symptoms, all these patterns and changes that I've been talking about, if you don't have any of that, it's usually not really beneficial to screen people for dementia. We usually start screening people for dementia when we have family members telling us, or even the patients sometimes they do recognize that things are changing with their bodies. So when we have these concerns being brought up to us, that's usually when we start the workup. The workup which I just talked to the gentleman about, blood work done, getting imaging done. We work the whole patient up in a comprehensive manner. That's when we usually start. And the way we screen is, again, it's linked to the way people with dementia change and their behavior changes. Sometimes their cognition can change. Cognition usually refers to the patient's cognition, how much they understand, how much they know. Do they know it's 12 o'clock? Do they know it's time to go to church? Do they still think it's nighttime? Do they think it's time to go to sleep when it's 8 a.m.? Things like that. Do they understand when you tell them that the car is waiting outside for you and they're just not getting up? These are things that refer to cognition, versus behavior is something that you witness in the other person. You see a change in their behavior, how they're behaving. They're being a little more sad than usual. They're being aggressive with you. They don't want to talk to you. Those things are referred to behavior. We also look at drug history of patients. Sometimes there are certain medications that can contribute to a patient's dementia. Sometimes, for example, sedative medications, which refers to sleeping medications. Some of us have difficulty with sleeping. We take certain medications for that. After a certain age, if a patient already has dementia and you're taking those sleeping medications, you're gonna feel a little more drowsy than usual. And if you're already feeling confused, it's natural that your confusion is going to get worse with those sedative medications. So that's what that refers to. We usually make it a point to make sure that the patients are not taking medications like that, because that can just worsen the whole situation over here. We also have these certain tests that we do in the office. We call it the MMSC. It's called the Mini Mental State Status Examination. It has 9 or 10 questions. It's just on one paper. That really helps us to test the patient's cognition, how much they're understanding. Can they follow our instructions? An example of that is on the screen over here, where there are 2 clocks. We ask the patient to draw a clock for us. And a clock is something we've been drawing ever since we were a kid. They can draw a normal clock with the normal arms of the clock, versus maybe someone with Alzheimer's or someone who's suffering with Alzheimer's will draw a clock in that way. And that is usually how we test how much they have deviated from their normal. And that is also a way in which we keep track of how they're progressing in the office when we see patients with dementia regularly. We do a comprehensive physical examination, because it's always good to just make sure that body is doing okay. We do lab tests, which is the blood work I was talking about. We test their blood, we check their cell counts, we check their thyroid hormone levels, we check their vitamin levels, we check their iron levels, things like that. And then imaging. We can do head CT scans, CAT scans, we can do MRIs. Sometimes patients can have some changes going on in their brain, which we don't know about, because we only get to know about it later. So imaging like this helps us in recognizing that early on. And we can end up doing imaging for patients because of the things that the family members are telling us. They've not been sleeping, they've not been talking to me as usual, they're changing. It's been more than 1 year since this has been going on, it's getting worse. That's when we do imaging, and if we see something, then we're gonna take care of it. Yes? Yeah, that's a great question. Thank you so much for that. So I think you're talking about a PCP, right? You're talking about your sister's PCP, the primary care physician. So we are usually the physicians who are the primary contacts. We see the patients first when their family members bring them to us. The other doctors who can take care of this are brain doctors called neurologists. Patients are usually referred from the PCP to the neurologist. So they are also some of the physicians who can take care of this. Other than that, again, as I said, in the hospital, what you were talking about, it is quite common for patients to have these changes inside the hospital because it's not their usual surroundings, right? It's not their home. Their family members aren't there with them. There's all this beeping going on in the background. That's normal as well. But usually when patients come back to their homes, they improve on that end, if that makes sense. She did? I'm glad to hear that. Yeah, that's something that we see quite often. We have a patient in the hospital, the family members are coming in, and they get really worried because the patient is extremely agitated. Yeah, she was. Yeah, so I'm glad she's doing well. That's what usually happens, and I'm glad that happened. They go back to their usual routine. They go back to seeing their friendly faces, their family members' faces around them, and they start feeling better. So I'm glad that happened. Any other questions? I know this is a lot of information. You can ask me if you have any other questions. No. Yeah. Okay. I can repeat that. Yeah. She asked me what really defines the difference between Alzheimer's and dementia. That is another great question. Dementia is just, you can think of it as an umbrella that we hold up in the rain. The umbrella has the top covering, that's dementia. And then umbrellas often have these drops at the end, the sharp ends, all surrounding it. The edges of the umbrella, that can be different causes of dementia. So Alzheimer's is going to be one of that. Alzheimer's is just something that can lead to dementia. It is a type of condition that can cause dementia. And Alzheimer's, when affects patients start feeling a little off. They're not recognizing you. They don't remember things. They don't like doing the same things they used to. They don't like doing the crossword or the Sudoku anymore. That can be Alzheimer's. That we call dementia, if that makes sense. It's just a condition that happens, which leads to certain changes, and those changes are what we refer to as dementia. So Alzheimer's is the condition, and dementia is the signs and symptoms that we see, the changes that we see in the patient. So this slide is talking about how we diagnose dementia. Something that we have talked about, these are the medical criteria that we use for dementia. If we see a significant decline in the cognition and the behavior of the patient as compared to before, this is extremely important, and this is why family members play a vital role in helping us recognize dementia, because they know what is the family member's normal. They know what the loved one's usual status is or how they are at home. And so if their learning memory getting affected, if their language is getting affected, their language getting affected in the sense they just don't want to talk, or they sound different when they talk now. Executive function just refers to you taking care of yourself on an everyday basis. You walking out to the car, you driving, you going grocery shopping, or your loved one going grocery shopping, your loved one washing clothes, doing the laundry, doing the dishes, things like that. Focusing and multitasking skills. Your loved one isn't able to focus on the conversation anymore. They keep drifting the conversation away, or they can't just talk to you, just not being able to have a usual conversation the way you used to with them earlier. That can be one of the changes as well. Yes.
There's a difference with the way the world is today, and so many things are going on, and all of a sudden you just don't want to watch the news, or you just don't want to, you just make changes because of what's happening in the world.
Yeah.
So there's a disconnect there.
Right.
But I guess it doesn't necessarily mean that you have dementia or Alzheimer's.
Right.
That happens too.
Right, that happens too. That's a good point too. Yeah, that is voluntary changes that you can be taking to just protect your own mental health, to protect your and that's okay too. Of course that's okay. There are lots of things going on in the world, but that's you taking that voluntary step and just stepping away for a bit and saying that I do not want to engage with this information at this point, and I I will see if I want to look at it tomorrow or maybe next month, but right now I'm not interested. The important point with recognizing dementia is often these changes are involuntary. The person getting affected isn't aware that it's happening. They think that life is just going on as it is, usually. But you know, as your loved one, as their loved one, you can see that this is not how they were. But that's the disconnect that you can often see with patients with dementia. They're not really aware that it's happening. They think life is just going on as usual, but it's really not. And you can see that living with them. The other things that we use for diagnosis criteria is memory problems. Memory problems, not remembering you just had food. You just had breakfast 10 minutes ago. You just don't remember you had breakfast. You begin to eat again. Things like that can end up affecting you. Or you forgot that it's been 12 hours since you had your last meal, or your loved one forgot, and then they just don't eat. And that is not good too. You need food at a regular basis, daily life. It doesn't happen only during delirium. So this is another important point. Delirium, as I said, is something that is often reversible and it's short-lived. It's of a shorter duration. Dementia is a longer thing that happens over a wide span of time, and you slowly see the progress in dementia. Delirium can just refers to a patient being a little confused, or a person being a little confused when the situation is not what their usual situation is. They are at a hospital. Nurses are coming in, blood work is being done. They have all these pipes and tubes all around their bed. Things are beeping in the background. People are going in and out. That would lead to confusion, and that's okay. That's normal. That is different from dementia, where people come to us and tell us that my mom or my sister has been not really acting the same way she used to. And it's been going on for 2 years at this point. It's a long-term thing. Versus delirium is more of a shorter-term thing that we see in acute settings, versus dementia is more of a chronic thing that slowly develops over time and changes over time. And then another one important point for dementia is, as I said earlier, we do blood work, we do imaging, we do a comprehensive test of the whole patient, a whole person, to make sure that we rule out everything else. If their confusion can be explained by some other condition, they just had a stomach bug, for example, they had a viral infection. If we can treat that, and then the confusion goes away, they start feeling better, they start talking to you again, that is one of the ways we help to rule out dementia. Because we want to make sure that it's not some other condition that is causing their confusion. That's how we make sure that it's dementia and not something else. So we want to test them, their whole self, to make sure that we're removing everything else possible. Could it be this? Could it be this? If it's not, okay, we go towards dementia more. Could it be this condition? If it's not, we go to dementia more. That's how we usually treat patients with dementia. Yes? Right. 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 That's another great question. And no silly questions over here. No question is silly. That's a good question. That is something that we will be talking about later in the presentation as well. So Dr. Grover is going to talk about that. But that's a good point. When you're feeling good, you can incorporate certain things, these little activities and things in your daily life which can prevent dementia from occurring. But again, it's something that we can't, there is no one thing that we can tell you and tell you just, oh, do this and dementia won't happen, if that makes sense. It's just one of those things we can try, and the patients can try. You can do certain things on a daily basis in daily life, like exercising, to stay healthy. But then if dementia can't be 100% prevented, if that makes sense. And then the specific things, Dr. Grover will be talking about it, there are certain things that you can incorporate into your daily life. These little things, little changes which help a lot. So what you can expect with dementia, just to give you an overview, because I know that was a lot of information just now, to know that it is a progressive disease. Dementia, once it affects patients, it more often than not usually progresses. By progression, I mean you see changes at a faster rate. You see the changes becoming worse over time. They get more severe over time. Um, they can go from mild to moderate to severe. Again, this is very subjective from patient to patient. This is very subjective because you know everybody is different. You know your loved ones best. Sometimes it can begin with some memory loss. It can begin with some subtle changes. They don't remember where they put their phone. They've been looking for their phone. And that's just the normal, that's something normal that happens with me too sometimes. But that can then lead to problems with executive function. They don't remember how to use their phone. They want to call someone and they're going somewhere else in the phone. They just don't know how to call people anymore. They want to talk to you, they're not able to call you. And that keeps happening over time. That can be a sign of dementia. They are not able to plan their outings with friends. They wanted to meet their friends this Friday. They don't know how to reach out to their friends to meet them anymore. It's just, they have just kind of, they feel a little lost as compared to their usual self. And you notice that living at home with them. And then impairment in daily activities just refers to they used to be taking care of themselves. They used to tie their own shoes up. They used to put their clothes out for the next morning. They can't do that anymore. They rely on you for that. They don't remember where the car keys are. They don't remember where the pillow is to go to sleep at night. They don't remember where the cover is for the bed. Things like that. That affects their daily life that family members can notice. That is a sign of dementia as well. And then I'm gonna, yes, please.
What if a person that like schizophrenia, is that in dementia or Alzheimer's? Do all of that work together or how does that go?
So that's a good question. Schizophrenia, even other things like depression in Alzheimer's, in dementia, all of these things can happen at the same time. Yeah, and then they just kind of make each other worse, if that makes sense, right? Because it does, yeah. Because if you're already suffering with dementia, you have these other things that will also cause problems. They're affecting your daily function as well. That's really important because then it's on physicians, it's the primary care physicians' duty to treat that, because we want to make sure, as I said earlier, we want to make sure that we're taking care of the dementia, but not forgetting the other things in their life. So if we see the patient, having schizophrenia, for example, or if they have a history of schizophrenia, we want to make sure that they are on the right medications for that. We want to make sure that their schizophrenia is controlled, their blood pressure is controlled, their diabetes is controlled, depression is controlled with medications, with other things that we can do, so we can focus on taking care of the dementia as well. So I think the best way to take care of that is to manage all the other conditions to the best of our ability, and then take care of that. Because if that's not under control, that's going to make the dementia worse. That is true.
That's right. I deals with that.
Yeah.
That's
Oh. Oh. Right.
And so, because when my husband took the test last year,
Yeah.
they couldn't tell whether it was dementia or was it the schizophrenia. So I got another test for him coming up
Okay.
next month, and they go see where it progressed, because they didn't know where it was, is he doing the schizophrenia, because he take medicine for it,
Yeah.
or is it the Alzheimer's or dementia?
Yeah.
But they could not give him medicine for it, because they didn't know
Which one?
which,
Yeah.
which were which. And I'm like, okay, but a lot of the things you have said, I do, and I'm like, you're talking about the real and the financial. I'm like, okay, thank you, Jesus, I already got that taken care of. I have to deal with that.
Yeah.
That gets mean, and they do forget, and they'll tell you, you taking this, you taking that. I've been accused of stealing as well.
Hmm.
If I'm stealing, at least my house no paid, I got somewhere to stay, and they don't eat. They'll say they want one thing, and then when you fix it, they don't want that, it be thrown away. And it, to the caregiver, it gets frustrating, because you don't know what to do. I had to learn to slow down with talking, for the brain to relate and catch on to what I'm saying.
Exactly.
And it do mess with the hearing, because my husband had lost hearing, some of his hearing in both of his ears, but trying to get him to wear a hearing aid. And it's a handful trying to deal with it.
Yeah.
And I try to keep my car keys out the way. But if he do get a car key, I gotta try
Yeah,
It's a handful.
it is. It's really hard, and sounds like you're doing the best you can. You're doing really well. It's really hard for caregivers. I agree. We understand. Yeah, and Dr. Grover is going to talk a little bit more about that. We have a section just on caregivers. Thank you so much.
Hello, thank you so much, Dr. Sangwan. She went over the causes, the diagnosis, and I'm going to focus mostly on the treatment and prevention aspect. Uh, that was actually an excellent segue into how we treat dementia, and that is by psychosocial support. Um, Certain causes of irreversible dementia that she went over, unfortunately, they cannot be treated, they can only be managed. And how we manage them is determined by how we take care of people with dementia at home. So who's a caregiver? Anybody, a trained nurse, wife, niece, son, husband, whoever is taking care of someone with dementia, taking care of their daily needs, would be a caregiver. Next slide. So what is that you can do as a caregiver to take care of someone? You interact with them, you maintain eye contact, you don't tell them that they have a disease because they don't have insight into their disease. You don't make them feel bad about it. You speak slowly and calmly, as you just talked about. You slow down, give them one instruction at a time because their brain cannot process things that it used to. Tell them what time it is, reorient themselves. Hey, it's Friday morning, the sun's out, or it's rainy, it's January 2025. Tell them the date and time, and try and reorient them as soon as possible, as much as possible, and give them really small, manageable tasks. Like, I remember this person had a grandmother who had dementia, so what they would do is just ask them to fold napkins. Just fold 10 napkins a day. They would feel useful, they would feel employed, and it's not very hard to fold napkins. It helps their fingers with all the arthritis. So figure out what works best for them. Next slide. Now you will have your share of challenges. They will try and they will get angry for no reason. They will try and leave the house. They will try and go to work. What do you do then? You redirect. Hey, I'm leaving for work. You don't tell them that, but you have not gone to work in the last 20 years. You ask them to help you with breakfast, or you ask them to fold the laundry, or you ask them to water the plants. Redirection is very useful with people with dementia. If they are upset, ask them why. It may be coming from nowhere, but it may be coming from pain. It may be coming from constipation. It may be coming from lack of sleep. There is something called the geriatric syndrome, which is something people experience even as they get older, usually over 65, where they can't sleep, they wake up at 4 a.m., 5 a.m. in the morning, and the people with dementia are also experiencing that, but someone with no dementia can communicate with me, but they can't. So you have to figure out how to identify it. You reassure them that you love them, that you're here for them. Sometimes it reaches a point where they cannot recognize you. Ask them who they think you are, and ask them to try and reestablish a relationship and tell them you're part of the same team. Next slide. You have to identify triggers, and you have to figure out a way to avoid them. If there is a certain person that bothers them, you would have to work on separating them from that person. Maintaining a consistent routine is essential, because any change from their day-to-day routine can be a trigger. So the same meal for breakfast every day, the same meal for lunch every day, is very essential. Do not disagree with them. Respect their thought processes, even if they're wrong, even if they think Bill Clinton's still president. That's okay. It does not matter. Just try and engage with them and involve them in conversation as much as possible. Next slide. this is something I really wanted to stress on. It's very hard being a caregiver. It's very hard to uh, take care of someone when you're hurting too, because, well, you don't have, mom is not the same anymore, and mom was your support system, and she's just not there in that capacity anymore, and I know that's very difficult. And you cannot pour from an empty cup. So it is important and essential for you to recharge, take your breaks, have someone else take care of them for a day or two, go out for a weekend, and try and ask for help when you need it. You taking up this task of taking care of someone with dementia is, um, it's a lot, and you should identify that and seek help when you need it, and you yourself should not be socially isolated. Um, that is something that is very essential to recognize. Next slide. Um, there is a lot of support out there, online and otherwise. There are a lot of support groups out there. You should consider joining them, ask family members for help, learn more about the disease. So there are multiple types of irreversible dementia. So how you figure out how they progress. Vascular dementia looks different. Alzheimer's looks different. Frontotemporal dementia looks different. So once you know what to anticipate, you will find yourself better prepared in that scenario. When you get to that bridge, it'll be easier to cross it. Talk to your doctor. There are a lot of support systems that we can offer at the doctor's clinic. So home health, support groups, psychological counseling for you. There is a lot that we can offer. So make sure that you ask. Next slide. Okay, so these were videos I wanted to show you guys, but we are having some technical difficulties, so I'll just describe them to you. What is sundowning? Does anyone know? Sundowning? Yes, yes. So usually towards the end of the day, some people with dementia can get extra fidgety. Why is that happening? They're just tired. It's just they've gone through all of these things throughout the day, and now it's catching up to them. So they'll start pacing around. They'll get very uncomfortable. They will try and leave the house. They'll try and get out of bed. It's very common, and a lot of people with dementia experience it. So how do you tackle that? You distract them. So if you know that they're not at their best at 6 p.m., at around 4 p.m., you distract them, you give them a task, you ask them to water the plants, you ask them to fold napkins, and that would help you deal with it. It's very common, and that's something we experience very often, even in the hospital. The night shift nurses, they have all of these people who are admitted with dementia sundown on us, and that becomes a challenge. Refusing medications. How do you deal with a person with dementia refusing medications? It's their blood pressure pill, they need to take it. What would you do? They don't know that they have high blood pressure. They don't know they have diabetes. So it will be very hard to get them to take that pill. One trick you can employ is get your vitamins and take them, and take your multivitamins together. Let's take our vitamins together. They're good for us. So if you tell them their pills are vitamins, they might agree to taking it. Sometimes, yes. Yes.
But some of them usually, blend it up or mix it up in their food and stuff.
They can. That's a great idea. It may change the taste of food, but if you can get away without it, yes, totally. I would agree. If you have to use these little tricks, don't feel guilty about it. Just go ahead and do that. They need their high blood pressure pills. I am very open to the audience contributing to little ideas and tips and tricks. So feel free to interrupt me and contribute just like she did. Um, they get up and leave for work. I went over this. They've not gone to work in 20 years. Don't tell them that. Don't tell them that you've not been employed for 20 years. Distract them. Again, redirection is what you do. The reason they want to get up and leave is because they don't feel useful at home, and it gives them a sense of purpose, which they don't have anymore. So, excuse me, give them that sense of purpose back. I think that's the trick here. Identify what they can do and empower them by giving them tasks. Uh, Hygiene refusals, that's something we also deal with very often. They don't want to step into the shower. Explore the why of it a little bit. Usually, as you get older, 80s and 90s, your body cannot regulate temperature like it used to. So you are going to be very cold in a shower. Or maybe they don't want to undress in front of you. Or maybe the water pressure is too high. Explore the why behind it and see if you can treat it. If you cannot, then there are hygiene wipes available. You can have your doctor send them over, or they're available over the counter to wipe them off and make sure that they're clean so that hygiene is maintained. But explore that why. Sometimes they refuse meals because they just forget to eat. Don't force them to eat. Pull up a chair, try and have their meal with them. Offer a snack if they don't want to eat. If you think that this is happening consistently, though, do go to your doctor. There are some medications that we can give for stimulating appetite. Sometimes some medications they're already on might be curbing their appetite. So to explore that, you would have to go to a physician. Sometimes they keep asking for food. You never gave me breakfast. Don't tell them that it's not time yet, or you just ate, or how are you still hungry? Don't shame them for it. Remind them that they told you that, oh, we're gonna eat lunch together at noon. We're just waiting for noon. Or again, distract them, give them another task to do. Maybe have them peel some bananas, or offer a snack if they're really hungry. So little tips and tricks that you can use. If anyone else has anything to contribute, I'm willing to take responses from the audience. Okay, next slide. Therapies for dementia. So there are a lot of things that we can offer. These therapies are also for people who live with dementia and people who take care of them. So it's always good to encourage people with dementia to talk to us, to express their emotions, to tell us what's really going on. To find hobbies for them is really, really important, and I'm going to go over it in some time. Stay connected to family, video calls with grandchildren, video calls with nieces and nephews, to make them feel a little more grounded. Healthy diet and exercise, that never stops. That we as doctors are going to keep preaching it like we mean it. Always getting as much exercise as possible, no matter what state of health you're in. In the hospital, even when someone's on a ventilator, we make them exercise. So it's important to keep that going. It regulates your hormones, reduces cortisol, that's a stress hormone. So I would always preach that. Next slide. Music therapy. Who here likes music? Yeah, me too. So I use it to calm myself down all the time, and it works at all ages. So bring out whoever they liked 50 years back. I still listen to some of that music and play it, help them relax a little, dance with them as much as they can, and try and celebrate, every moment, no matter how tough it is. Next slide. Talking about exercise, so little things. Have them stand up. Raise your calf. That's gonna exercise your calf muscles. Make sure that there's support. Wrists. Open and close your hands. Whatever you can do. Walk around the house. hold their hand, have them walk around the block. Make sure everyone gets about 20 to 30 minutes of exercise. Encourage them to get up from the bed, sit at the side of the bed. Ask your doctor about physical therapy. Outpatient physical therapy is available. We have a couple of clinics here in Spalding that can offer that, and they'll teach you some tricks tailored for your family member or for you that's gonna help them keep active and engage in exercise. Next slide. Aromatherapy. Okay, this is a short one, just making sure that the house is clean. I actually forgot mentioning it in one of the caregiver slides. It's very important to keep the house clutter-free because you don't want them falling. Make sure it's a clean house that smells nice so that it avoids confusion. Next slide. Art therapy, painting, knitting, as much as they can do. Have them call the grandchildren over, have them paint. That would also help. As much as they can do tabletop games, bingo, dominoes, whatever they liked when they were younger. Light therapy. Now this is really important. I do want you to pay attention to it. Don't keep them in the darkness during the day. When it's daytime, make sure all the windows are open and there's enough sun. And when it's nighttime, don't expose them to bright lights at night. You want their circadian rhythm to stay normal. So day and night regulation is very essential in anybody with dementia. Next slide. Okay, so there are some medications out there. These are acetylcholine esterase inhibitors. I know that's a mouthful. There's a neurotransmitter that makes nerves talk to each other in the brain, and this particular one increases the levels of that neurotransmitter. Now, as I said, these are not revolutionary medications. They may help manage dementia in some people, but they may not in the rest. And they come with their side effects. They can cause an upset stomach, dizziness, confusion. So neurologists do prescribe them, but they only work in a few, and you need to watch out for these side effects. Next slide. Vitamin supplementation. So these vitamins are out there. There's some research where they talk about taking vitamin B and vitamin E supplementations in Alzheimer's, healthy fatty acids. I would say that you cannot, in this case, you cannot out-medicate a healthy diet. So just making sure you get your vegetables and you get all your nutrients when you're younger will prevent dementia in the older age. I know there was some question about prevention of dementia. I can address that right now. So some causes of dementia, like vascular dementia and Alzheimer's disease, have been linked to the same risk factors as heart disease. So much so that in some literature, we say that Alzheimer's is like type 3 diabetes, and they're looking into therapy for diabetes also for preventing Alzheimer's. So think of eating healthy and exercising, getting your portion of protein, fiber, and healthy carbs every day, and about 150 minutes of moderate exercise. If you do that when you're younger, that would prevent some causes of dementia. Vascular dementia is just repeated strokes that keep happening in your head. So what causes strokes? High blood pressure, smoking, high cholesterol. So treating that, seeing your PCP regularly, I would say that would prevent dementia when you're older. Next slide. I think I already went over this. I already went over this. Yes, ma'am. That's an excellent point that she made. She said that children may give the person with dementia something that they're not supposed to have, and they don't know what's going on. You can, you can educate your children. Like when there's a newborn in the family, we educate the children about how to behave around that newborn. We can do the same to some extent with an elderly person, that grandmom was not who she was 5 years ago, so you have to be a little more careful around her. Video calling is one safe way to engage them with their grandparents, I would say. Next slide. Okay, let's go over some little questions. Now, I'm not going to diagnose anyone today. We're just going to go over some riddles and see where we're at. Okay, are we ready? All right. Next slide. Okay, I will like someone from that row to answer. You're participating in a race. You overtake the second person. What position you're in? I think Dr. Sangwan, you got this one wrong, right? Let's see. Okay, how many for third? Okay, one. Okay, two people for third. How many for first? Two people for first. How many? Okay, three people for first. How many for second? One person, 2, 3, 4. Was that you raising your hand, Mr. Hodo? No. Okay. It is. So I think I saw 6 hands. I think the seconds have it. It's the second person. So if you overtake the second person, you'll be in the second position. But good job. Thank you for trying. Mary's father has 5 daughters: Nana, Nene, Nini, Nono. What's the name of the 5th daughter? Okay, I got 1 Nunu. What was that, ma'am? So I'll say that one more time. Mary's father has 5 daughters: Nana, Nene, Nini, Nono. What's the name of the 5th daughter? Nunu, okay. We already got a Nana. What was that? Mary? That is correct. That's correct. The 5th daughter. The 5th daughter is Mary. But I mean, that's the answer we anticipated. No, don't worry. You all don't have dementia. It's just little riddles. Next question, please. Okay, I got this one wrong. A non-verbal person gets into a shop and to buy a hairbrush by imitating the action of brushing the hair. He successfully expresses himself to the shopkeeper and the purchase is done. Next, a blind man comes into the shop and wants to buy sunglasses. How does he indicate what he wants? So the non-verbal person, the person who can't speak, goes like that. What would the blind person do? Okay. Any other answers? So I'm getting a lot of this and this. That is correct. He just talks about it. He can talk. He's blind, remember? Okay, all right. These are some resources out there available online for you all to reach out to. There's a Alzheimer's Association helpline in case somebody wants to take a picture. And there is help out there. Just ask. Next slide. Oh yeah, I actually did not stop for questions. I apologize. Does anyone have any questions? All right, it was lovely speaking to you guys. Thank you for this honor. We do have some flyers out here talking with some information about dementia, and we have a clinic right next to the hospital. If somebody needs primary care, uh, needs a primary care doctor, we accept all patients, even the ones without insurance. We would be happy to help. Um, to help. So just reach out. There's a lot of information out there. Okay. Thank you. Thank you.
As you witnessed, there's a lot of information about dementias out here. We just want to give you a taste of it, 2 hours worth, to let you know that it's the information out here. We think WellStar, as well as I need to introduce Dr. Gailey. He's the Associate Director of the program here in Griffin.
Thank you, Mr. Hodo, for having us here today. So, to all of you, my resident, those are the resident doctors that are in training. Dr. Grover is a third-year resident in training. Dr. Sangwan is a first-year resident in training. They both did an amazing job. So, if you have any questions, feel free to ask him now or even after later. So what I'm here to tell you is we have the clinic called WellStar GME Clinic. GME Clinic means Graduate Medical Education Clinic. So what it means, it is clinic run by the residents, but there will be supervising doctors, myself, and there are 2 other faculty doctors that will supervise the residents. They get trained, but we take care of patients like everybody else. And on top of it, we spend a lot of time. Our residents do spend a lot of time per patient compared to when you go to your own primary care doctor. I'm not telling you to switch doctors to us. I'm telling we are available. If anybody needs, you are welcome to come to us. And we also have a neurologist in town with WellStar. His name is Dr. Devarapalli. We call Dr. D. And any of people have dementia, we can refer the patients to the neurologist also. So we have the services available. I just want to bring it to your attention. If you need more information, we have flyers here. And we take everybody, insured, uninsured, Medicaid, everybody, and we'll take care of them. I do see some challenges in the community here. Some people, they don't have insurance. We still take care of them, and they do have some barriers to care, such as not able to afford medications. We do, we make the plan per individual, meaning if somebody does not have money to buy medications, there is something called goodpill.com, Goodpill Pharmacy, that delivers medications to the patients. We identify them, we enroll them in that pharmacy. Most of the medications are $6 for 3 months. That's how we try to individualize the plan. If you have commercial insurance, it's covered by the insurance medication, then not a problem. So we are there to help anybody and everybody that needs medical care. So please, if you have anybody, you can refer them to us. I'm not telling you to switch doctors from your primary care doctor, come to us. I'm just telling anybody that needs care, we are there to help. Okay. Any questions?
So are you able to treat in addition to the primary care providers?
Pardon?
Would a patient be able to bill separately?
No, we will be considered as primary care providers. Yeah. And Dr. Lulu, I would like to invite Dr. Lulu. She is one of our resident doctors. We do give informational talks in the hospital. It's once a month, and I think she got some flyers. If any one of your family members are interested, you can join us for the talks in the hospital too. Yeah, Dr. Kamar is also here. Is also our resident doctor. He's sitting in the back. I'm just introducing him to you.